Good afternoon and welcome to this afternoon's webcast. It will be conducted at Kanchi Kamakoti Child's Trust Hospital, Chennai. The presenter will be our postgraduate Dr. Vasudha, and the faculty will be Dr. Ganesh and myself, Dr. Lalita Janakiraman. So after the presentation and a brief discussion about the case, we will have a very brief discussion on inborn errors of metabolism, rather the inherited disorders of metabolism. Over to Dr. Vasudha.
Good afternoon everybody. I am going to present a 3-month-old male infant, Hemendra Krishna, hailing from Nellore. Informant being the mother, the history is reliable. He was brought to our hospital 1 week ago with the complaints of cough for 8 days and seizure, 5 to 6 episodes of brief seizures on day 6 and 7 of illness. This illness started with cough 2 weeks ago. He was having recurrent bouts of cough associated with noisy breathing. There was no postural variation. The child was having difficulty in feeding and sleeping. In the last 2 days, there was associated fast breathing, for which the child was taken to a local hospital and was admitted. And on the day 2 of admission, that is day 7 of illness, child developed seizures in the form of uprolling of eyeballs, deviation of head to right side, and posturing of the upper limbs. The following 24 hours, he had 5 to 6 episodes of similar seizures, which lasted for less than 5 minutes. For which the child was started on some IV medications, and a CT scan was done. And according to the mother, that is said to be normal, and the child was shifted to this hospital for further treatment. After admission to our hospital, the child had seizures lasting for 30 minutes. Yes, sir.
With your chief complaints alone, which system do you think is involved?
Respiratory system is involved, sir, primarily.
Okay.
And associated seizures are there.
Okay.
It can be due to hypoxia.
No, I'm not asking you the causes.
Yes, sir.
What system do you think?
Respiratory and nervous system are involved, sir.
Okay, fine.
So what was the primary concern?
Concern for the parents.
Parents' main concern was cough, because he was unable to feed or sleep. Their primary concern was cough.
Okay, go ahead.
After admission to this hospital, child had a seizure lasting for 30 minutes, for which the child was given some other IV medications, and child was drowsy all the day. There was no history of fever. There was no history of poor feeding or vomiting prior to this illness. There was history of mother noticed that the child was having stiffness of limbs from the first week of life, which is more in the lower limbs, and she gives history of fisting of palms, which is more for the first 2 months of life, and now it is better. He has not attained his social smile or neck holding yet, and he can't recognize mother, but he can fix at her face when she is talking to him. As per mother, he responds to loud sounds by crying, and there is no history of turning towards the sound. There is no history of any abnormal movements or past seizures, no history of irritability and excessive crying. Mother noticed that the child is having abnormal eye position, but there are no abnormal movements of the eye. There is no history of any regurgitation of feet. The child always moves his limbs. There is no positive movements and no history of involuntary movements. Mother has no concerns about the head size or facial features. And coming to feeding, the child...
1 second, Dr. Vasudha. You said mother had noticed stiffness of the limbs.
Yes, ma'am.
Was there any scissoring?
No scissoring. She is not giving any history of scissoring. Only fisting she is giving history, ma'am.
Fisting, and you mentioned that mother noticed the
yes, ma'am. When mother is trying to carry the child, he is stretching his lower limbs, and she thinks that the lower limbs are more stiffer than the upper limbs.
History of presenting illness.
No, sir.
Okay.
I'm not finished yet.
No, do you think you have fully highlighted us on the developmental delay with spasticity with your history?
I tried. Yes, sir.
You are progressing, sailing through the central nervous system.
Yes, sir.
So what do you think is the primary problem identified in this child? Is it a background of a child with a developmental delay, a spasticity, now having an intercurrent infection, subsequently developing seizures, or seizures may be the first manifestation in a child with an underlying developmental delay? What do you think is the problem from the history?
The child had developmental delay and this stiffness of limbs, and now he is having some acute infection which precipitated the seizures. He never, for the last 3 months, he never had any seizures. Respiratory infection. It may be due to aspiration, but there are no history of regurgitation of feet and no previous respiratory distress or anything. This is some lower respiratory infection which triggered the seizures in this child who had developmental delay and stiff limbs.
Okay.
Does that give you a clue to anything?
He may have his underlying CNS abnormality.
Okay. Good.
The child will, before this illness, child will be able to feed for 10 to 15 minutes once in 2 to 3 hours, and he watches 6 to 7 times per day with good stream. And there are no bowel abnormalities. There are no history of recurrent respiratory infections, no history of poor weight gain or abnormal odor or abdomen distension in the child. Family history is a third born to third degree consanguineous parents, and mother had history of 2 abortions, the first one being the spontaneous, and it occurred at, in the 4th month of gestation, and the second one was the induced one which happened in 3rd month. The other 2 older siblings are girls, 6 and 4 years respectively, and they are developmentally normal and attending the school. Antenatally, mother is a known HbSAg carrier for the last 6 years, and she was registered and was in follow-up with her obstetrician monthly. There was no history of any febrile illness in the first trimester. She had taken her iron and folic acid supplements, perceived fetal movements from the 5th month of gestation, and she had history of polyhydramnios in the 7th month. There is no history of gestational diabetes or hypertension. No history of premature rupture of membranes or bleeding PV in the 3rd trimester. There is no history of fetal distress just before the delivery, and all the antenatal scans done were normal. The child was delivered at 37 weeks of life by emergency cesarean section within 6 hours of onset of labor, indication being the previous cesarean section, and the child cried immediately after birth, and he is 2.5 kgs at birth, and the baby was initiated on feeds within 3 hours of initiated on breastfeeds within 3 hours of life. He was given HbSAg immunoglobulins on day 1. Vaccine was not given. Within 24 hours, he developed bluish discoloration of fingers and toes, for which the child was taken to the newborn unit, and the child was admitted there. Baby was admitted there for 2 days, not ventilated. And at that time, they noticed that he is having jaundice, for which he was given phototherapy on OP basis for the next 5 days. No history of any blood transfusion and no history of ABO incompatibility. At the same time, parents were told that baby is having right foot abnormality, for which they were prescribed some exercises. Social history was they belong to a lower income.
You said child developed some bluish discoloration,
Yes,
right?
ma'am.
Do you think that was a seizure or
No, ma'am.
it wasn't?
No, ma'am. They belong to a low income group, and father thinks that the child is having an acute problem, and he may have normal development in the future. The child is immunized with BCG, 1 dose of OPV, 2 doses of hepatitis B, and 1 dose of DPT and H influenza B vaccine.
You said hepatitis B was not given.
Was not given at birth, ma'am. But Immunoglobulins were given, but the vaccine was not given at birth. I want to summarize my history. This
Audience, so what else from the history would have given a clue? Do you think the history is complete? Do you want any other information? Yes. Rajaram?
You think she has given a complete history, or is there any other thing that you would like to know? Because she is ready now to summarize and tell you something from the history itself. So is there anything else that you would like to know?
So from the history, do you think this child has got a problem or not a problem? Yes. Is it an acute problem or it is a chronic problem?
Chronic problem with
Chronic problem. Why do you say it's a chronic problem?
developmental delay is there. The background of developmental delay, there is a
There is a history of too early to call it a developmental delay because child is only 3 months old. But whatever the milestones the child should have achieved by this time, right? The child has not achieved, right? Okay, fine. So it is a chronic problem. Fine. Now, where is the problem? Is it in the respiratory? Is it in the central nervous system, or it is a multi-system disorder? Pardon? Come on, you have heard the history, right? Okay, basically it looks like a central nervous system problem because the child has got, since birth, child has not attained milestones. Fine. Now, what is the site of the problem?
cortical problem.
Cortical. Okay, why do you say it's cerebral cortex? From the history, has she given any other information?
Spasticity.
Okay, only seizures. Do you think anything? Spasticity. Okay, mother herself has noted stiffening of both lower limbs, as well as she has observed that the child constantly keeps his or palms closed. Okay, fine. Right. If at all there is a problem, what is the problem? Do you think of?
Actually, there is chance of perinatal asphyxia.
No, there is no history of perinatal asphyxia. The child was born by an LSES, cried well at birth, birth weight was 2.5 kilos. Okay, fine.
37 weeks LSCs was done indication.
previous LSCS.
What else? So there is no history of perinatal depression per se, right? And she has said child was noted to have some bluish discoloration of the extremities on day 2 of life, warranting an NICU stay. The mother is not sure whether that was a seizure or not a seizure, but she feels that it was not a seizure because have they given any medicines during this period, any anti-epileptic drugs that was administered during the neonatal period?
She don't know, sir. Mother was, she underwent cesarean, she was in different
So
hospital.
she was in a different hospital and the baby was admitted to an NICU in another different hospital. Okay, so they are not very clear about.
No, ma'am. No, ma'am.
So that will give you a clue, no? If it was a seizure, most likely the child would have been put on some medication, right? So the fact that the child wasn't put on any medication, it is unlikely that it would have been a seizure.
Okay, so there is no history. What else could be the cause? Pardon? Sepsis. No, there is no history of fever. There is no history of poor feeding. There is no history of irritability. Right? Child was taking feeds well, had some cough. That's it.
There's one other history she gave in the newborn period.
Kernicterus. Again, to say kernicterus, this baby did not have any exchange transfusion. He said in the history, the baby has not received any blood transfusions for jaundice and was treated with phototherapy probably as an outpatient basis. Probably would have required phototherapy for only transient period of time. Okay, fine. So you are not able to come to the cause for this problem based upon the history. So what else you would have asked if you are in that case? Head size.
She noticed, he said very clearly, mother has not noticed any this thing in the head size or in the facial features.
So there is no difference in the head size when compared with the previous siblings, and there is no history of any abnormal cases that has been observed. Okay, fine. What else?
No, sir.
There was no history of any respiratory distress per se in the newborn period. Fine. What else? What else? So has she made a mention about the weight gain of this child over a period of time? She gave the history. There was no history of
Poor weight gain, I told.
what was the weight? What was the weight at birth? What was the weight now?
4
Because
kgs now.
basically this developmental delay she has been observed right from the newborn
First week
period.
of
Baby
life.
was found to be stiff. right? So how was the weight gain of this child? Number 2, is there any history of involuntary movements that has been observed?
No, sir.
Did she find anything
She
abnormal?
mentioned.
No, sir.
Fine. What
Any
else?
feeding difficulty?
No, the child can
So
suck
you
well
said
when
child was posturing and all that, that's why I'm asking.
the child is a third born, mother feeds the child, this child feeds equally as the older siblings.
Okay, fine.
Was this mother advised some physiotherapy?
Till now they have not seen any doctor for this stiff limbs. After consulting doctor for this cough only, they came to know.
Now, what is the reason for the seizures that have occurred prior to 1 week? Prior to a week?
The child was being nebulized at that time and he was crying. He was crying for a long time, mother told, and suddenly he developed uploading a voice. He became quiet and.
So, is it an hypoxic seizure? Is it an hypoglycemic seizure? Or a first episode of seizure event that has occurred in this child? So, what do you think?
First episode of seizure, because the child had 4 or 5 episodes subsequent to the first episode of seizure.
So, it could be anything because we have not got any other information, further information from the parents. So, all these 3 things could be a possibility.
So to think of anything further, you always say that I would like to complete the examination before I can give something more definitive. Okay.
Yes.
So now, where do you fit in now?
So far with the history.
So far with the history. Come on. So you heard the history. Now, anyone of you can say what is the problem and do you summarize?
See, by the end of the history, we should have some working diagnosis in our mind, right? It may not be 100% right, but a few DDs we should have by now.
See, by the end of history, you should have 4 or 5 differential diagnosis. End of physical examination, you should narrow down your differential diagnosis. End of investigations, you should still narrow down and come to a conclusion. Okay, so that is the idea of eliciting a good history, doing a good physical examination. So what's the probable causes? What are the probable causes of this?
We'll go to Vasudha. Come on, Vasudha. What are the probable differential diagnosis from the history?
I'll summarize first answer. It's a 3-month-old male infant, third born to third degree consanguineous parents with developmental delay, seizures and spastic diplegia with congenital right foot anomaly without any history of perinatal depression.
Don't commit yourself to spastic diplegia at this stage.
Okay.
Because you haven't examined the child. You're just going by whatever the mother said.
Mother said.
So you can say the mother's history of
Stiff
stiffening
limbs.
of the limbs, but don't put it as spastic diplegia.
Yes, ma'am.
Prior to your proceedings of your physical examination, how far are you all convinced the history taking of a seizure episode in this child? Do you think she has given the complete information about this? Seizure, yes, there was a seizure. All seizures lasted for less than 5 minutes, that's it. Do you think what type of seizure, which part of the day has it occurred? Is the seizure related to any feeding, anything?
Are all those things
Do you
important?
think it is important or less important?
Why?
But come on, one at a time, one at a time.
Early morning seizures in the metabolic disorders due to
Seizure which occurs following a period of fasting, right? If we give a clue to the underlying diagnosis of, could you name 1 or 2?
galactosemia,
Glycogen storage.
After fasting,
When does it happen?
GSD, glycogen storage diseases,
Glycogen storage disorder.
name other few causes of seizures that occurs after prolonged fasting.
Yeah,
That
correct.
is-
So short period of fasting most often occurs in glycogen storage disorders. Prolonged fasting most often hypoglycemia occurs in fatty acid oxidation defects.
A seizure that occurs soon after feeding will clinch to the diagnosis of galactosemia as well as your fructose intolerance. Okay, right? So these two are the possibilities. Yes, fine. Now, did the seizures occur during sleep or it occurred in the awakening state?
First episode of seizure, mother has noticed. After that, the child was shifted to ICU in that hospital, and the rest 5 episodes, only doctors told that the child had seizures.
No, was it during sleep or
The child was drowsy during that episode. I'm not
What
sure
is
whether
the
the child.
importance? Why did he ask that question?
My
Simple
Benign myoclonic.
myoclonic type of seizures will have occurred. Suppose if the child had infantile spasms, right? What do you think is the probable etiology? No, the causes for infantile spasms are many, right? In the context of a child who had developmental delay with seizures, right? And we are suspecting a metabolic disorder. What metabolic disorder will you think of?
Now, which of the metabolic disorders rather has most commonly having infantile spasm as one of the
Has been closely
Association.
associated with. So this is presence with skin manifestations. They manifest as organic acidemias, and when you have they have unusual body odors also, right? Pardon? Maple syrup urine disease. Okay, so MSUDs have been linked to infantile spasms. Okay, yes. Now could you please tell your differential diagnosis, what you thought of in this case?
cerebral malformations.
Okay, yes.
Because
okay.
Cerebral malformations. Agree? Pardon? Yes or no? Yes. Okay. Sometimes lissencephalus, cystencephalus, holoprosencephalus, all can have a manifestation. Okay. Right. Then.
inborn error of metabolisms.
Okay. Inherited disorder of metabolism. Why do you think inherited inborn error of metabolism in this case? Pardon? Okay. Yes. This child is born to parents of third degree consanguinity.
Consanguineous parents.
What
Okay.
percentage does this third degree consanguinity has got relation to the transmission? Suppose if the baby is born to parents of first degree consanguinity, second degree consanguinity, third degree consanguinity. You have 3 patients, they are born to 3 categories. Okay. So what is the percentage of genetic transmission in these children? If it is first degree, what is the percentage that can be get transmitted? Pardon?
Correct.
So 50%.
50.
Okay, if it is second degree, it is 25, right? Third degree, it is 12.5. And beyond third degree consanguinity, it's only 6.5, which is more or less similar to the other disorders that can get transmitted in the general community. Okay, so that is why we are eliciting the history of consanguinity. Okay, fine. So this child is born to parents of a third degree consanguineous marriage. That is one. Okay, what else? Previous to abortions, was it induced or was it spontaneous?
One was induced, one was spontaneous, sir.
Okay, fine. Then, so spontaneous abortion, yes, you can give one.
See, more than abortions,
Abortions,
they are
it's a
usually
sibling
early
deaths.
sibling deaths. Unknown cause, siblings just, sibling deaths. That is more common.
Okay, fine.
Okay,
Then what
anyway,
else?
that's
What
okay.
else? What else?
Then
What else?
usually when
Late
does it
onset
get
of
precipitated?
seizures. Acute illnesses.
Yeah,
Acute
see the
illness.
child may be normal, any acute stress, that is when most of these metabolic disorders get precipitated. So maybe, that could be one of the other things.
Again, developmental delay, seizures, and the last one was a status epilepticus, right? So all these are pointers towards IEM, right? What other differential diagnosis you have? So one is you finished off with cerebral malformation, that is any structural abnormalities in the brain. Okay, the most common is going to be a neuronal migration disorders. Number 2, you gave the diagnosis of IEM. Fine, what else?
What else?
Chromosomal abnormalities.
Chromosomal abnormalities. What are the pointers to say it's a chromosomal
History of
anomaly?
previous abortion.
Okay,
Congenital anomaly. Foot is abnormal.
so the right foot was
Consanguinity.
okay, consanguinity.
Okay, that's fine. Anything else? Any other?
But neurocutaneous syndromes. Why do you think in terms of neurocutaneous syndromes? Developmental delay, seizures, only those.
No, this child didn't have infantile
The way
spasms.
she described, the baby doesn't have a infantile
Seizures.
spasms. Okay, right, fine. Now the seizures are well controlled, right?
Yes,
So
sir.
that's what you
After that, no further seizures.
And there were no external skin markers that has been noted by the mother. Okay, there were not much of capillary spots or any hemangiomas where the mother has obviously noted. If she has noted, she would have told us, right? So it ranks less. I will not say it is uncommon. It ranks less in the differential diagnosis. Fine. What else?
Perinatal asphyxia. Next.
Yeah.
Perinatal asphyxia. There is no history, but this is a preterm child with diplegia, with more stiffness, more in the lower limbs. We can think of.
I think you have got this diplegia fixed.
Okay, fine. Yes. Okay, anyway, so at the end of your history, you have some 4 or 5 differential diagnoses. We'll go to the clinical examination and then we'll try to see whether we could narrow down our differential diagnosis. Okay?
Yes,
Right.
sir.
Yeah.
So any other clarifications from the history so far? Anybody needs it?
Hemendra is examined when he is lying down on the cot. Eyes are open. He is not interested in surroundings, moving limbs. NG tube, nasogastric tube in situ. Coming to vitals, heart rate is 96. Posture, which flexion at hip and knee, elbows are also flexed. The posture is not suggestive of any not very actively, but movements are there, limb movements are there, but not normal. Heart rate is 96 per minute, peripheral pulses per
Stop here. Have finished off the general examination?
No, sir. Should I finish it off first?
Yeah. Finish off the general examination, then comes your pickle, then comes your vitals, anthropometry, developmental assessment and the systemic examination.
Yes, sir.
Okay. Present in this order.
Head appears small, small shape is normal. The divergent squint is present. On face, he is having low set ears, a little down slanted eyes, and retromathism. Right foot club foot is there, so CTV is there. And coming to the pickle, pallor, icterus is absent, pallor is present, no cyanosis, lymph nodes are edema. And vitals, heart rate 96 per minute, peripheral pulses well fed regular, respiratory rate it's 48 per minute with subcostal lower intercostal and supraclavicular retractions. BP is 80 by 50 millimeters of mercury. Coming to the anthropometry, his weight is 4 kgs. Height 56 centimeters and head circumference 37.5. Everything is yes, sorry, sir. It's length is 56 centimeters. Head circumference is 36.8 centimeters. All falling less than third centile. Head circumference is less than 3 standard deviations. Coming to the CNS examination.
Interrupting you.
Yes, sir.
You said on general examination the head size is small.
Yes, sir.
Was there any overriding of sutures? What about the fontanelles? All this you should comment.
Yes, sir.
Okay, is there any premature closure of anterior fontanelle?
No,
Is
sir.
there any
No.
overriding of sutures?
No overriding of sutures. AF is open. Anterior fontanelle is open.
And then is there any neurocutaneous marker what you have noted in the skin? When you say skin is a part of general examination.
No.
But somebody gave the differential diagnosis of neurocutaneous syndrome.
No
We still
neurocutaneous
have
markers.
that as in the differential diagnosis. So whether this baby had that?
No, sir. I didn't notice anything.
Does this child have microcephaly from your
Yes,
examination?
ma'am. Yes, ma'am. Microcephaly is there.
You have plotted on the graph.
Yes,
And it is below?
below 3 standard deviations.
Another thing in eyes, you said the baby was not following objects.
Not following.
Yeah. Did you observe any
No, I didn't
cataract,
tell you.
corneal clouding, all those things in the eyes? You narrated about the low set ears. You said about the retrognathia. Right? The baby was not following objects, right? So was there any corneal clouding that
No.
has been observed? Was there any cataract?
No, sir.
Okay.
I can't find any abnormality in the eyes.
So you have to mention those. You mentioned a divergent squint.
Yes, ma'am.
So at that time you also mentioned the other negative findings. Okay.
Okay, ma'am. On nervous system examination, the posture I already explained. So he is not able to follow the objects, not fixing on the light. Pupils are equally reacting to light, equal in size. extraocular movements are normal, fundus appears normal, no facial asymmetry, no mouth deviation, not responding to sounds, no startle response, a gag is present, tongue is in the midline. Coming to the motor system, posture, the child is lying down on the cot with his shoulders and elbows flexed, hip and knee joint is also flexed. Bulk of the muscle appears to be normal. Tone on inspection appears to be normal. On examination, spasticity is perceived in the upper and lower limbs. On 180 degrees examination, the child is while pulling to sit, head lags behind and his back is rounded, and on ventral suspension, head is falling below the level of the trunk, and he is not holding it momentarily. Limbs are also falling just below the level, but they are not they are in the level of the trunk, so just below. And pulling to sit. In prone position, he is able to put his side to the he is able to clear off his nose, but he is not able to lift his chin or shoulders off from the couch. Deep tonal reflexes are brisk. Morose asymmetric tonic reflexes are absent. Coming to the abdomen is soft. He is having hepatomegaly.
Primitive reflexes.
I can't elicit asymmetric tonic reflex and morose in this child.
You said it's absent, right?
Absent. Then
It should be present at this age or it should be absent?
it should be present. Asymmetric
What
tonic
is the
reflex should be
agenda?
present.
The child should have.
The child is turning to your side.
Does the child roll over?
Roll over.
Turning,
No, you said-
not turning fully side. He is turning to one side.
You said there is no head control at all.
No head control. He is always lying down with head in sideward position only, sir.
No, the child turns over completely. Then, is the ATNR still there or is there?
ATNR is not there. ATNR is not there.
So this child is not turning over, no?
Not turning over, ma'am. He can turn to one
This
side.
child is only 3 months, and if this child is turning
This
over,
child is turning. He always lies down in the side. He lies on his side only always.
See, still you can explain. If the child is able to turn over, it's because of the excessive spasticity the child is able to turn over.
Turn.
But that is not the one what is expected. Okay, right?
any other primitive reflexes you try to elicit?
Palmar grasp, it's not there.
Not there.
Not there.
What about sucking, rooting?
Sucking and
Rooting.
sucking and rooting are there, ma'am.
It's there.
There.
Is it normal at this age? If it is present?
Sucking is present at this age, it's normal.
Rooting.
I'm not sure. No, it's not.
Okay. When does rooting disappear?
Audience, anyone can you highlight when does your sucking, rooting, momental?
Just a quick run through of the primitive reflexes. When does it appear? When does it disappear?
Come on, you are all weak in primitive reflexes. So make sure you just read all those primitive reflexes. What is the pathophysiology behind their appearance and the disappearance? Right? When do they appear? When do they disappear? And what is the clinical importance of this? Okay. Right? Everything has clinical importance. Right? So make sure you learn all those things. Fine.
Per abdomen. Rest of the systems.
CNS. Other parts of CNS have you covered? Do you think you are covered?
Sensory system, I can't examine this child. Cerebellar
Sensory
system, I can.
yes, it's a small baby, you need to tell sensory system. But what about cerebellum, skull, spine? And you said about spasticity, right? Is the tone uniformly increased in all 4 limbs, or is there any difference between the tone of the upper limbs versus the tone of the lower limbs?
AC கொஞ்சம் அணைச்சிரு.
Tone of upper limbs is less than tone of lower limbs, sir.
So that means lower limbs are
More
stiffer
hypertonic.
when compared to the upper,
Upper
limbs.
limbs.
Right? What is the power you observed in this child? Does the child able to kick? Does the child able to hold the objects when placed in the palm of them? So what is the power you observed? Is the child able to lift the arms above the level of shoulders?
Child is able to move the limbs against gravity. It's more than 3, sir.
But
He is able to lift his limbs
Okay,
against the gravity.
okay.
I can comment against resistance.
Okay, fine. Then other systems?
Other systems, coming to the respiratory system, on inspection, both the equal movement on both the sides. There is a respiratory rate is around 48 per minute. Retraction, increased work of breathing with chest retractions observed. Air entry is equal on both the sides. No added sounds.
Okay, so it's normal vesicular breath sounds in both lungs.
Both sides.
You could not appreciate any added sounds.
Yes,
Okay,
sir.
fine.
But-
What about the trachea? Trachea is in the midline?
Trachea is in the midline.
Okay, fine.
So before we go further with the examination, just ask her to demonstrate and send the child back.
So, okay. Just demonstrate that tone.
Tone?
Said there is microcephaly.
Yes, sir.
How did you measure the head circumference?
Okay.
Just demonstrate that much. Sorry, don't just. Demonstrate the tone. No, Papa, can you check this? சரி அப்படி மடியிலே வச்சுக்கோங்க.
ఇది కొంచెం తీస్తాను ఓకేనా. His posture, he is flexing the upper limbs at the elbow and the lower limbs are flexed at the knee and the hip joint.
So there is no scissoring on both layers.
No scissoring, sir. And fisting is also not there now.
How else do you look for scissoring? Normally,
We hold the child.
hold the child and
That,
can
yes, yes. It's tough to move at the initiation of the movement.
So the tone is increased
Yes,
if-
yes, yes.
Okay.
After few flexions, it became easy to move. Tone is increasing.
Okay. So like this. Hold. Look at. Okay. Fine.
head circumference. இந்த தொப்பி கொஞ்சம் கழிச்சிடுங்க. Okay. How should you ideally take it? I mean, try.
We should stretch a non-stretchable tape.
Yeah. And
And it should, this tape should pass over the occipital prominence and the
Yeah.
supraorbital ridges.
Okay.
And we should measure it over the temporal prominence by crossing over method.
and you're supposed to measure.
3 times and take the
Yeah, and
average.
take an average, because this is something that most often you are asked to demonstrate during the exam. We all take it for granted. Not that you all don't know it, but you are asked to demonstrate, and at that time don't struggle, because you all have done it in the ward. It's not a new thing that you all be doing in the exam. Rajesh, take them to the ward.
Inspection, that is the active movements, what you look, what does the baby does, right? Then about the passive, right, that is your flexion, extension, all those things. Then special maneuvers, for example, there are various maneuvers for hypotonia, like the scarf sign, the elbow sign, all those things you have to make a mention, right?
In this age group, you have to demonstrate all that. Okay, it's not just only in the newborn, because this baby is still small, no? So you have to do the scarf sign and your square window, popliteal angle, just to know that whether there is hypotonia.
Any findings in the abdomen? You said about the respiratory system.
Hepatosplenomegaly is there.
Okay, could you please describe the hepatosplenomegaly?
Liver is 4 centimeters below the right coastal margin in the mid-clavicular line. It's soft. Span is around 7 to 8 centimeters. Spleen is 2 centimeters below the left coastal margin. It's also soft.
Liver span is normal or?
It's increased for his size, ma'am.
Whenever there is a hepatomegaly, you have to give the full description of the liver. Okay, you said the liver is soft. It measures for it is 4 centimeters below the right coastal margin. Where? Is it in the mid-clavicular line? Is it in the anterior axillary line? Or whether it is below the xiphisternum, xiphoid process?
Mid-clavicular line.
Then
Right,
number
it should
three,
automatically
what is the
come.
consistency? Is the liver smooth? Is the liver hard? Is the liver firm? Right? What are the margins? Is it a rounded margin? Is it a sharp margin? Okay, does the liver move with respiration or not? Is there any tenderness while palpating the liver? So all those things, no? Right? What all has been taught to you in
Surfaces.
Smooth. Surface is smooth. It's moving with respiration. It's non-tender.
Okay, so basically it's a soft liver with a rounded margins. Okay, right, fine. What about the spleen similarly?
Spleen, it's non-tender, soft, moving with respiration. 2 centimeters below the left coastal margin. Not sure in which.
So along the splenic axis. Okay, whenever you describe the spleen, you should always describe along the splenic axis. The spleen becomes enlarged in size, or sometimes the spleen may go towards the left side also. Okay, so that you have to make a mention. Okay, fine. Yes. What about the cardiovascular system?
Cardiovascular examination is normal, sir.
Okay, fine. What about the musculoskeletal system? You said the child has got right foot abnormality.
Yes,
so could
sir.
you please describe that one?
The foot is internally rotated. Dorsal aspect is arch of the foot is increased. It's internally rotated with the dorsal aspect facing more medially. And say talipes equinovarus virus, right foot. Normal.
Now you sum up your history with your findings and then narrow down your
Yes, sir.
diagnosis.
This is a 3-month-old born to third-degree consanguineous parents with failure to thrive, developmental delay, seizures, spasticity, more in the lower limbs, with mild facial dysmorphism, skull and hepatosplenomegaly. With this picture, I would like to think about inborn error of metabolism. As my first provisional diagnosis, and second one is intrauterine infections and chromosomal anomalies.
You mentioned anything about the reflexes? You said spasticity.
This
You said
yes, ma'am. In this age
in
group.
this age.
Group. Okay, fine. So, what are you said your first differential diagnosis as
Inborn error of
inborn error
metabolism.
of metabolism? Yes. Now everybody would have heard the history as well as the physical examination findings. Why do you say it's an inherited disorder of metabolism from your history?
There's a history of consanguinity with
So history of consanguinity. Fine.
previous abortion,
With, with spasticity from very early on, with the first week of life, with now child having hepatosplenomegaly with seizures, with an intercurrent illness that has worsened which has precipitated seizures probably.
Fine, is that okay? So one, yes, IDM could be a possibility in this child because child is born to parents of third degree consanguineous marriage. Number two, there is history of developmental delay. Number three, there is history of seizures. Initially it started with 1 or 2 episodes, finally the child had a status epilepticus. Number four, the child has got a hepatosplenomegaly. Number five, there is impairment in vision, impairment in hearing. Okay, right, other siblings are found to be normal. Okay, with this, yes, you can think of IDM or inborn error of metabolism as one of the differential diagnosis. Fine, what else?
One of the clues, no, which can differentiate between birth trauma, intrauterine infection and IEMs. I mean, it may not be 100% right. The child is usually normal at birth, unlike birth asphyxia or any of those children, and subsequently develop problems. I mean, that is one of the clues.
So in this maybe these were all the general, these were all the pointers to come to a differential diagnosis of IEM. Otherwise, what are the clues? When will you suspect IEM in a child, in a given child?
Poor feeding.
Come on, one at a time.
Previously,
Okay, previously well child.
One at a time. Okay, you have the mic.
So previously well child with sudden deterioration. Okay, fine. That can
Early
be
onset
still
seizure.
intracranial hemorrhage, anything that is CNS infections, all those things again previously well child can deteriorate suddenly. Okay, right, fine. What else?
Neonatal seizure which has transiently improved and other again having a seizure. Early onset seizures.
Early onset seizures could be neonatal sepsis, right? Unexplained seizures, okay, or difficult to control seizures, okay, that points your diagnosis of a IM. Fine, what else?
Vomiting, recurrent
Okay,
vomiting.
previous history of sibling death or a positive family history, okay, a child who was already a propionic acidemia. Fine, now the baby is, second baby is born, the child also has a developmental delay with seizures and abnormal body odors. Yes, you have to suspect a IM. Fine, what else? Unusual body odors. Fine. Yes, this is always unusual body odors. What are all the body odors you found unusual to suspect IEM? Maple syrup urine disease?
Burnt sugar.
Burnt sugar urine. The smell of a burnt sugar. Fine. Then,
Tyrosinemia.
pardon? Isovaleric acidemia? It's a sweaty feet odor, okay. The moment you remove your socks, right? So that odor may be there. Fine. What else?
Tyrosinemia.
Tyrosinemia. What?
Cabbage.
Boiled
Boiled
cabbage.
cabbage or rancid butter. Okay, fine. Then what else?
Phenylketonuria.
Phenylketonuria.
Musty odor.
Fishy or must.
Musty odor. Fine. Then. Okay, so there are so many odors, right? For example, Hawkins urea can have a swimming pool odor, all those things. You should have smelled it, then only you could appreciate it. Fine. Otherwise, these are all the textbook descriptions. Fine. Then what else? So unusual body odors. Fine. What else? Yeah, poor feeding. Okay, right. Then what else?
Lethargic.
Poor feeding, lethargy, failure to thrive, unexplained vomiting. So all this, again, think in terms of a inherited disorder of metabolism. What next? Come on, answer.
Dysmorphic fascia related with
Abnormal faces. Okay, abnormal faces. One example for an abnormal faces.
Zellweger
Syndrome. Okay, can have an abnormal faces. Fine. Or any very long chain fatty acid defects. Okay, can have an abnormal faces. Fine. What next? Pardon? Acidotic breathing. Okay, fine. Then encephalopathy. Okay, unexplained encephalopathy. Okay, right, fine. Then what else? hepatosplenomegaly, fine. Then ambiguous genital, again congenital adrenal hyperplasia or any disorders of sexual differentiation, fine. Then what? Abdominal, so okay, chromosomal anomalies. I am asking about inborn errors of metabolism. Fine. Hypoglycemia, okay, so hypoglycemia, metabolic acidosis, fine. Skin manifestations, okay, see some of these children, they can have purely the skin manifestations like perioral, perianal, dermatitis, right, multiple eczemas, okay, so all those things can have, fine. Then so poor feeding, that's what, poor feeding, vomiting we have described, fine. What else? Unusual presentation of a simple illness, okay, fine. What do you mean by that? Louder please.
With simple infection itself, child will present with serious symptoms.
Mild form of illness can turn out to be a lethal, right, or a more serious one, okay, fine. Then
Neuroregression.
multi-system involvement, yes, fine. So neuroregression or a neurodegeneration, okay, so these are all some of the pointers which has been described in the textbooks, right. When these are there, you have to have a high index of suspicion. It is not that IEMs are rare, right. Only thing is, if we have to have a high index of suspicion to pick up these cases in the day-to-day life, okay, fine. Yes, so one differential diagnosis we have covered. Second, what is your next differential diagnosis? Intrauterine infections. Can anybody say what are the pointers for and pointers against?
No IUGR.
Previous abortions. Was there an abortion prior to this delivery?
Yes, sir. One spontaneous abortion was there.
Okay.
Microcephaly.
Okay. So there is a microcephaly. There is a splenomegaly.
Failure to
There
thrive.
is a failure to thrive.
Seizures.
Okay. Seizures. Right. Impairment of vision and hearing. All this, yes. Intrauterine infections is one of the possibility. Fine. What other differential diagnosis you have?
Chromosomal anomalies.
Chromosomal anomalies. Why do you think it's what is the reason? What are the
Dysmorphic
points for-
faces. This child is having dysmorphic faces.
Okay.
Congenital anomalies, consanguinity, failure to thrive, again developmental delays.
So, want to parents of consanguinity, that is one. Number two, child has got low set ears, retrognathia, there was a club foot, right side club foot was there. Child also has got impairment in vision, impairment in hearing. Okay, these are all only by your clinical assessment. We are not yet confirmed by doing any special investigations. Okay, fine. So, chromosomal anomalies is one of the possibilities. Fine. What other differential diagnosis? Intrauterine hypoxia. So baby had a good birth weight, right?
Good birth weight, sir.
Baby cried well at birth. There was no history of any uteroplacental insufficiency from the history. Maybe that, suppose if they have documented a pH, right? So they may be there. Fine. Then what else? Any other differential diagnosis?
Hypoglycemia means undetected hypoglycemia,
Undetected hypoglycemia for what?
causing the cerebral palsy, causing the developmental delay.
So that you should have made a mention. Baby was fed on day 1 of life.
Yes, sir. Within 3 hours of life, the baby was started on feeding.
And there was no documented hypoglycemia also. Suppose if the baby had fits in the newborn period, and they would have told the parents that because of low sugar the child had seizures. Okay, unless we go through their records, their newborn discharge summary, everything, we cannot arrive at a definitive conclusion. Okay, fine. Yes. So now, how do you work on this case?
Renal function.
So far, are you clear? Is there any doubt?
Any other details any of you want to offer?
Neuroregression. Yes, neuroregression, but the thing is the child has not acquired any milestones yet. Okay, and baby is also too small, 3 months, probably a partial head control, right? So that may be one milestone we would expect, and vision and hearing should be there, and the social smell should have been there, right? But this baby has not acquired anything. So neuroregression may...
It's too early to say neuroregression. See, that baby may still be having some neurodegenerative disorder, but too early to say neuroregression.
Anything else? A storage disorder, everything comes as a part of metabolic. Okay, fine. So you need not even think about it. Fine. So how do you work up this case?
Child came with seizures. We'll start with renal serum electrolytes.
This child has come with seizures. Now, if you are thinking in terms of a metabolic disorder, which anticonvulsant would you avoid?
Valproate.
Why? Okay. Yeah. Okay. So you will control the seizures.
Seizures. We look at the electrolyte levels, any acidosis or anything. We can serum lactate, pyruvate, ammonia.
Okay. So you will do the metabolic workup. Okay.
Yes,
What else?
For
the seizures per se, anything else you would like to do?
neuroimaging.
Yeah, that and all comes. You are
Later.
managing a child in the emergency room. Okay.
Hepatosplenomegaly.
What were the two common problem with which this child came?
Cough, chest X-ray we should go for.
Okay.
Hepatosplenomegaly is there. I would like to do CBC, blood counts and...
So whenever you are given a situation 1, there are investigations which help you to confirm your diagnosis. There are investigations which help you to support your diagnosis. Okay, fine. So your blood counts, what does it say? Suppose you think an IAP, metabolic disorder.
And cytopenia if it is present.
Yeah.
We can think of storage disorders.
Storage disorders,
Does
does it have
any other metabolic condition wherein you will get
Infiltrative, it is osteopetrosis. Or something.
any other metabolic disorder wherein pancytopenia is a feature?
Think. I'll give you a clue. These child, they are very sick at presentation. Okay, they have severe acidosis. They have encephalopathy. They have difficult to control seizures. They may have skin manifestations. Okay. Okay, any organic acidemias. Okay,
Organic
acidemias can have leukopenia and thrombocytopenia. Okay, so that may give you the clue, right? Anemia, yes, because of the child has not been taking enough. Okay, so there may be anemia, right? Fine. Then what other investigation? Serum electrolytes you said, and you said about the acidosis,
Yes,
right?
sir.
Low bicarbonate gives a clue to that underlying
Chronic
gives a clue to the
acidosis.
diagnosis of IAP. 3. She said about ammonia, lactate, and pyruvate. So you are all the resident doctors. Fine, we just give instructions to you over phone. Please do this. Now, how will you collect samples? This is most important
Very
to arrive at
important.
a diagnosis of underlying IAP.
What precautions will you
Right?
take? How will you advise?
Ideally, these samples you should collect during the crisis. So when now this child has come to a crisis. Imagine that this child has come to a crisis. So how do you collect samples? So how many of you are aware? Most of the times nurses are collecting blood samples. So what special instructions will you give them?
How do you collect for ammonia? How do you collect for lactate? What are the special precautions?
So basically ammonia. Okay. So ammonia, when you do, the sample should be a free flowing, right? Then it should be, you should have to inform the biochemistry lab that we are going to send the sample for blood ammonia estimation, and it has to be processed immediately. Okay, so then you should start collecting the sample. It should be from the vein. It should be a free flowing sample, because the moment you squeeze, what happens is the ammonia level goes up, right? And the samples has to be transported in ice pack, right, immediately to the laboratory. Not that you collect the samples, you keep it and do other work and then come and send the sample, because there may be false elevations of ammonia levels that can happen, right?
And it has to be processed immediately also.
Okay, right. Second, lactate. How do you collect sample for lactate? Pardon? Yes.
Okay.
Ideally, it is an arterial sample. Sometimes if it is difficult to get an arterial sample, you can go ahead and collect the venous sample. 2, ideally lactate should be collected in a fasting state. Okay, right? Third, again this sample also has to be collected in a free flowing way, and it has to be sent in a tube, the fluoride tubes, not the ordinary, the EDTA or the red top tubes, the fluoride tubes. And again you have to inform the lab that it has to be processed immediately. Sometimes you can see the normal lactate level is up to 2.4, right? Sometimes there may be transient increase in lactate levels, one because of the difficulty in sampling or the delay in processing, whatever it is. Suppose if you squeeze, the levels may go up. Suppose if the lab process it late, then the lactate levels may go up. Fine. Similarly for pyruvate, how do you collect samples?
We always write no ammonia, lactate, pyruvate. So we should know how to collect, because you are in an institute like this, sisters do it. Tomorrow you are going out, you are going to have your own practice. You need to know how to collect and send a sample properly.
Because these are all very, very important, right? Otherwise what happens is ammonia level may come at 120. So you may not be, you are nowhere near the diagnosis, right? A lactate level may be 3.1. It may not be that significant rise. Okay, so you may not reach a differential diagnosis. Okay, so that's what these are all known as critical samples. Okay, for any inherited disorders of metabolism, right? Similarly, pyruvate also, it should be a free flowing sample. It has to be transported in ice to the laboratory, and for pyruvate you use the tubes with perchlorate added to it. Okay, that will prevent the breakdown of pyruvate from the red blood cells. Okay, so the perchlorate tubes you have to send it to the laboratory, and please instruct that they have to process it immediately, not that they collect, do all the other investigations and then come and estimate this. Okay, fine. Then what else? What other investigations? I am talking about the first line investigations.
Hepatic involvement is there, LFT we can go.
Okay, so there is a hepatosplenomegaly, so liver function test should be done. Fine. Then urine for what? Am I bothered about urine pus cells here? Urine for reducing substances and urine for ketones. Very, very important.
Yeah.
Urine for ketones. Okay, fine. Then what next? Okay, ABG to document the pH. Yes, the metabolic acidosis for documentation. Fine. Then what next? If there is a CSF, if you are able to draw a CSF, you can always simultaneously estimate the lactate and pyruvate in the CSF. You can put the lactate pyruvate ratios. Fine. Then
You said urine for reducing substances, no? Yeah? Anything you would specify? For what do you do that mainly? Yeah.
Benedict's test, right, to detect all those reducing substances which are present in the urine. Okay, so these are all the preliminary investigations that should be done whenever you suspect a child with the inherited disorders of metabolism. Please remember the mnemonic is GALEK, G-A-L-E-K. Okay, these are all the compulsory things that you should do. G stands for glucose, A stands for ammonia and acidosis. So basically you have to draw bicarb and ABG. L stands for your blood lactate levels. E stands for your serum electrolytes, and K stands for your ketones. Okay, urinary ketones. So this is the basic mnemonic for a preliminary investigations that we all do whenever we suspect a child with the underlying IEM. Fine. Now what are the other investigations?
Neuroimaging, urine for metabolic screening.
Neuroimaging in this baby. Fine. What neuroimaging will you do, and what are all the findings do you expect?
What specific findings you may see in specific metabolic disorders? Of course, one is an HIE sequelae. Apart from that, that's what he's asking. Suppose a child has got a large head, has got some cyst, and child has got some dystonia. What does that point towards anything?
No.
No, right, somebody said
history
that.
of dystonia. Child has got
Sorry.
large head. Child is having a developmental delay. You are suspecting a neurometabolic disorder. What neurometabolic disorder and what is the imaging finding? Sometimes most of the times the radiologists pick up and give us a clue. Glutaric aciduria. So what is the MRI brain finding? Pardon? Very? Right? Fine. Suppose if the child has got large head. Okay. Right? You find the NAAP going up. What's your diagnosis? Kenavans. Okay. There is a bilateral symmetrical white matter hyperintensity. We call it as a tigroid appearance. So what is underlying neurometabolic disorder? Alderbad spasticity. Okay, fine. So these are, yes, MRI with MR spectroscopy definitely has got some role to establish or to give a clue for the underlying diagnosis of an IM. Fine. What next? What other investigation?
You have done imaging. What next? You have done the first line investigations. You have done imaging. Now what else will you do next?
Hearing and
Yes.
optal assessment.
So hearing and optal assessment. Okay,
Yeah.
fine. Hearing, of course, you do the BERA, right? Because being a small baby, you do a BERA. Fine. Optal examination. Now, you are the pediatrician. You have to request your ophthalmology colleague to look into specific areas. What are all the eye findings that helps us to give a clue to the underlying IEM? Start from the anterior aspect of the and go towards the posterior aspect.
Cataracts.
Cataract. Okay, fine. So what are the what are the IEMs which can manifest as cataract?
Galactosemia.
Galactosemia. Fine. What is the type of cataract? Oil drop cataract. Fine. What next? Wilson's disease. What is the type of cataract?
Sunflower cataract.
Sunflower cataract. Okay, fine. Then
That is myotonic disorder. Not
okay,
IEM.
fine. Then that's
That
galactosemia.
galactosemia.
Loeys syndrome can have cataract. Okay, Smith-Lindley Optis syndrome can have cataract. Okay, so galactosemia and Wilson's disease, don't forget. Fine. Yes. Then before cataract, you will be looking at the cornea, right? So suppose the baby has got corneal clouding. So what are all your differential?
Mucopolysaccharidosis.
Pardon? One at a time. Yes, mucopolysaccharidosis. Fine. Then. Fine. Then. So Wilson's disease also can sometimes have a corneal clouding. Okay, fine. Yes. Now you go into the chamber of the eye, right? Suppose if there is a lens displacement, what's your differential diagnosis? Pardon? Homocystinuria and Marfan's. Fine. Suppose you see a cherry red spot. Now you are into the fundus. You see a cherry red spot. What are all your differential diagnosis? Pardon? One at a time. Niemann-Pick disease.
Now, they're all expert in this.
Gangliosidosis,
G1 gangliosidosis.
Tay-Sachs,
Then
Niemann-Pick's,
Niemann-Pick's.
Sands.
Rogers, fine. Then you see now you are into the fundus. So once you identified the cherry red spot, fine. Now, if it is a retinitis pigmentosa, what's your differential diagnosis? Not sure about it. Mitochondria, I'm not sure about it. Okay, most common A beta lipoproteinemias. Okay, where these children have loose stools, right? You can have the retinitis pigmentosa appearance. Okay, refsums can have a beta the retinitis pigmentosa. Fine. Optic atrophy. Okay. So your optic atrophy, yes, maybe mostly your Melas, Murph, right? All this leaks encephalopathy, all those things can have a optic atrophy. Okay, fine. So these are all the eye manifestations of a child with an underlying IEM. Okay, and similarly, based upon your head size, okay, you can narrow down your differential diagnosis to some extent. Can you name some IEMs which has got microcephaly, Vasudha?
Phenylketonuria,
Phenylketonuria.
Crab's disease,
Crabs,
NCL, neurosystem lipofuscinosis.
Can you name some IEMs with macrocephaly? Canavans, Alexanders, metachromatic
MLDs.
leukodystrophies, then glutaric acidosis, don't forget G. Okay, fine. Now, based upon the skin manifestations, you said skin is normal, right? Can you name some skin manifestations? Can you relate some skin manifestations to IEM? Yes, maple
Yeah.
syrup urine disease,
Biotinidase
deficiencies, multiple
Carboxylase
carboxylase deficiencies,
deficiencies.
all. There may be varying clinical manifestations. Acrodermatitis, enteropathica. Okay, so these are all some of the skin findings with the IEM. Yes. Tyrosine type.
Type 2, Richner and Hart, no? That's the one they have palmar plantar keratosis.
Okay, fine.
Yeah.
So these are all some of the IEMs with skin manifestations. Okay, fine. Now can you name some IEMs with liver and spleen involvement?
Gangliosidosis, GM1 gangliosidosis.
Okay.
Um,
Glycogen storage disorders can
Disorders,
have a liver,
GSDs.
spleen. Yes, fine. With seizures they can manifest. Okay, fine. They can have developmental delay because of GSD type 3. Okay, fine. Then mucopolysaccharidosis. Yes, they may have some amount of developmental delay. They can have large head. They can have abnormal faces. Okay, fine. Then Zilberger syndrome, again abnormal faces with the hepatomegaly. Fine. Then okay, tyrosinemia in the newborn period. Usually the sick newborns who present with acute liver failure. Do not forget tyrosinemia. Okay, fine. They have jaundice, they have prolonged PT, they can have encephalopathy, they can have hepatomegaly. All features will be there. Okay, fine. Usually they are sick newborns. Fine. Then what next? One big chunk. What we all see, the lysosomal storage disorders. They can have liver, spleen. They can have developmental delay. They can have seizures. Okay, so that group can have these features. Fine. All mucolipidosis, mucopolysaccharidosis, anything can happen. Fine. Then
See, remember, most IEMs, no, they present like sepsis only in the newborn. So when you find all the septic screens are negative, then probably you may think about metabolic problems.
she said about consanguinity. Right? Most of the IEMs are autosomal recessive. Can you name some IEMs which are autosomal dominant? No. Fibrosis X-linked recessive. Fine. Then hypercholesterolemias
And
porphyrias.
Porphyrias.
Okay, porphyrias can have a autosomal dominant type of inheritance. X-linked recessive inheritance, can you name something? Hunters, Fabry's, adrenoleukodystrophies, Menkes recessive. Okay, fine. So these are all most of them are autosomal recessive. Few of them can be there can be a variation. Okay, fine. Then
anything else?
anything else? What are the clinical manifestations? Suppose IEMs with only mental retardation. They will be wandering all around, but their intelligent quotient may be low.
Phenylketonuria.
Phenylketonurias, mucopolysaccharidosis, okay, right, MPS, they can have developmental delay, but they will be walking, right, you see their IQ levels, they may be low, okay, fine. Then IEMs with cardiomegaly, cardiomyopathy, Pompey's disease should be given due consideration. Okay, fine. Yes. So she has finished the first line investigations: a blood count, liver function test, renal function test, urine, and then she has done a specific ammonia lactate pyruvate. Then she has gone for a neuroimaging. Fine. Now, what are all the second level investigations will you do in a child with suspected IEM?
Urine for metabolic screening.
Yeah.
Urine
Yeah.
for metabolic screening.
Okay, what else?
What else?
MR spectroscopy.
Yeah, one somebody said there. Okay, before that anything?
Yeah.
Yeah, right.
Urine for organic acids and blood for your tandem mass spectrometric
Spectrometry.
analysis. Okay, so that may give a clue to the underlying diagnosis. See, they are not confirmatory test, but still they will be, you can narrow down your diagnosis.
See,
Okay?
from that you can send the enzyme assay. You cannot send all enzymes, right?
Unless you get a clue. then you cannot do the other investigation. So most of the times tandem mass spectrometry needs only a dried blood spot, okay, right? And this is one of the tests which nowadays recommended for the newborn screening, okay, right? So you can identify some of the common problems like your medium chain acyl-CoA dehydrogenase deficiency. All those things can be picked up by your maple syrup urine disease, can be picked up by your TMS, okay, fine. Then what next? Once they pick up, then you can do the plasma as well as the urine for quantitative estimation of amino acids by your HPLC method. Okay, so that will come as a little later part. Fine. And then comes your enzyme assays. Suppose you know specifically, right, deficiency of sphingomyelinase A, deficiency of sphingomyelinase B, deficiency of some galactosidase, all those things if you are able to pick up, then you can request for those specific enzymes alone. And then you can have a molecular genetic testing, right? So it's available for glycogen storage disorders and most of your other storage disorders where you can identify the gene what is responsible for causing this problem, and then you can request. So this will be able to, you can offer a counseling for your subsequent pregnancies, okay, right? Suppose if this is going to be the index child, okay, fine.
And always remember, when you have an unexplained death like this in a suspected newborn or slightly older child, preserve 10 ml of urine and 5 ml of plasma. If, because we can process that and maybe come to a diagnosis which will help for a genetic counseling for the next child. So invariably we are not able to do that when that happens, but it's very important to preserve that sample.
So knowing this, now how do you treat IMs?
See what happens in IMs. Accordingly you should treat. No, so
Yes, sir.
just think.
I'll give you this same patient. This is a 3-month-old child. Okay, had some developmental delay, had a respiratory infection, seizures, coming to the emergency room. Okay, you do the investigations, blood counts are normal, right? Electrolytes are normal, there is no metabolic acidosis, right? Glucose is a little bit low. It's not a hypoglycemia but lower when compared to that of a normal, right? You are requesting for a ammonia, lactate and pyruvate, okay, right? So now the ammonia comes as 1200. Now what's your diagnosis and how do you want to treat? Right in front of you the child is seizing.
So what does this child have?
Come on.
Urea cycle disorder.
Okay, so urea cycle disorder. Fine. Now how do you want to treat this? No, with this, the initial phase is only this you can suspect, right? It may be a urea cycle disorder, it may not be a urea cycle disorder.
Child has hyperammonemia without
High ammonia
acidosis
level,
from what he
there is no
said.
metabolic acidosis, there is no ketosis, there is no hypoglycemia, right? So you are making the diagnosis of a urea cycle disorder. There are many enzyme deficiencies which may cause urea cycle disorder, but you have not yet established that. But now how do you want to treat this patient?
Control the seizures.
What's your primary aim now in this child?
To control the seizures.
Control the seizures, then remove or reduce the ammonia levels. So what will you do?
No.
For dialysis,
Anything you will try before going for dialysis?
speak to the nephrologist, right?
Before that, what is it that you will do?
So acute management, what will you do?
Control seizures, she said. What else?
Laxatives can reduce.
Yes, Vasudha.
Laxatives can reduce this.
Which one?
Laxatives, they can reduce ammonia production from the gut.
Seizing, no.
Sodium benzoate.
Sodium benzoate.
Okay, fine. What is the, how do you give sodium benzoate? How many of you are aware sodium benzoate is available or not available?
Available.
It's available.
Available.
It's available as injection form or it's available as parenteral form?
Powder.
It's available as a powder form, so you have to place in an NG tube. You have to give somewhere between 250 to 400 milligrams per kg per day in 3 to 4 divided doses depending upon the clinical situation. Okay, with periodical monitoring of the ammonia levels as well as the child's general condition. Okay, fine. How does the sodium benzoate act to reduce your ammonia levels?
What does it do?
No, that's all different. I'm asking you what is the rationale of administering sodium benzoate to a child with hyperammonia? So this benzoate will get this converts your ammonia into the hippuric acid, so that will be
Excreted.
by the kidneys. Okay, fine. So what other medication will you give? Arginine. Okay, fine. One condition where arginine should not be given in a child with underlying suspected urea cycle disorder. Arginine deficiency. Okay, right? Yes. Then other thing. Sodium phenyl butyrate. Okay, it is not available here, but there are books recommend sodium phenyl butyrate also to be given, right?
Sodium benzoate?
Sodium
I mean, there
phenyl
is
butyrate.
availability as intravenous preparation. We don't have it, but it is there.
Arginine, then carnitine. Okay, right? Carnitine, it helps to lower down the ammonia levels as well as it improves the myocardial function. Okay, so carnitine can be given at a dose of about 100 to 150 milligrams per kg per day. Apart from that, restricting all your proteins, giving a high dose in the glucose infusion. Okay, right? So this helps to manage a case of your urea cycle disorder. Okay, fine. Suppose this baby is day 2 of life. Okay, right? Day 1, baby was delivered by cesarean section. Right? So they have been giving IV fluids. Next day mother has come, she has given breast milk. Soon after feeds, this child has seizures, you document hypoglycemia. Now what's your diagnosis?
Galactosemia, fructose.
Why do you say it's a hereditary fructose intolerance? Galactosemia, I do agree.
When
That
do
mother
they
is-
develop fructosemia? When do they develop this?
Honey or honey.
Okay. So,
Fruits, honey.
so here there is a case one where you give a trigger and that worsens the condition. Okay, the trigger here is the lactose that is present in the breast milk. Right? It worsens your galactosemia and the child starts having a seizures and this thing. So what is the treatment for this? Correction of hypoglycemia. Fine. Yes. Then
Diet
avoid
modification.
breast milk. Okay, right? So these two things that has to be borne in mind. Suppose this is a 3-month-old child. Okay, right? The child was well, right? And then the baby has taken its feeds in the night at 9 o'clock. Morning 4 o'clock, the child has seizure. The mother rushes the child to the hospital. What's your differential diagnosis?
Glycogen storage.
Pardon? Glycogen storage. Early to manifest the GSB, but what is the most common?
Fatty acid oxidation defect.
Fatty acid oxidation defect. Okay, fine. Right? The baby in fatty acid oxidation defect, what will be the findings? There will be
What happens to the ketones?
hypoglycemia, but
No ketones.
there will not be
Any urine
any
ketones.
ketones. Okay, right? So there will be hypoglycemia, but there will not be any ketones detected. That means it's a fatty acid oxidation defect. Right? And also you have to think in terms of a MCAD. Okay, medium chain acyl CoA dehydrogenase deficiency, where this is the time once they are exposed to the prolonged fasting, they develop a seizure and they manifest the underlying condition. Okay, suppose a newborn has got ketones in the urine. What's your differential diagnosis? Generally, you see new ketones in urine of newborns? No, most of you don't see newborns producing ketones in the urine. Okay, right? If they have ketones, then you always think in terms of your organic acidemias and those sort of workup. Okay, fine. Then what other specific treatment is available?
What is this other specific treatment? He is giving you a clue also.
Enzyme replacement.
Other than that, enzyme replacement for some conditions, very few conditions right now.
Bone marrow
Yeah.
transplant.
Dietary modifications.
Modification.
Okay, fine. So what are the special formulas that are available? Are you aware of it? MSUD
Yeah.
formulas. Okay,
Yeah.
Ketonex is available. Fine. Then
Tyrosinase.
tyrosinema, there is a special formula for tyrosinema available. Plus you have got the NTBC or nitisinone treatment that is also available. Fine. Then organic acidemias and propionic acidemias, MMAs, there are special formulas available for this. Then some special formulas to reduce proteins like Profree, Elalipid. Okay, they are all available for treatment, especially in case of your hyperammonemias. Okay, fine. So, is there any doubt?
Always remember, with all these special formulas, you need to monitor the child, and some of the essential amino acids has to be replaced.
So far to sum up, she has presented a 3-month-old who had developmental delay right from early newborn period. Baby had seizures by 3rd month of life with impairment in vision, impairment in hearing, born to parents of 3rd degree consanguinity, had small head size. Okay, on examination the baby has microcephaly, has not gained weight. Okay, then child has got hepatosplenomegaly and neurological examination shows spasticity. Right? And considering this, you arrived more or less at the differential diagnosis of IEM, and we have seen what are all the physical findings in various types of IEM. We have seen what are the blood tests that has to be done as a part of initial screening for any child with suspected IEM, how to collect blood samples, the neuroimaging findings, and we have touched a little bit upon the diet, the various formulas that are available for management of specific metabolic disorders. Okay, now we have some few PowerPoint slides which we'll go through, so that will give you a complete picture.
Okay, thank you, Dr. Vasudha. I'll just go through just a brief sum up. I think most of these things Dr. Ganesh has already discussed. So just to recapitulate, I'll just run through these few slides. Where's the slideshow, man? I can't see only from here. Slideshow here, Kadla. Okay, yeah, fine, thank you. Okay, we'll just see, we don't need to know in detail the biochemical pathways. Okay, all that we need to know is a high index of suspicion in a critically ill child, and I think all those points we have already discussed. As we said, most often they will present as like sepsis, or they may present with intractable vomiting. You will think it is actually pyloric stenosis. Such severe vomiting can be a presentation of IEM. Okay, so we need to know when to send and what tests. And this again we have discussed, when do we suspect inborn disorders of metabolism. So we have already mentioned about consanguinity, a positive family history, unexplained sibling death, seizures, hypertonia, persistent vomiting, failure to thrive, unexplained jaundice, unusual sepsis, unusual odors, extensive dermatitis, mental retardation, either a macro or a microcephaly, coarse facial features, dysmorphism, developmental regression in an older child, myopathy, cardiomyopathy, intellectual deterioration in school performance, and ketosis, acidosis and hypoglycemia. I think all these points have already been discussed. Okay, this is just a quick way to remember. In your alphabetical order, they can present as an acute encephalopathy, they can present like a sepsis, a cardiomyopathy, unexplained death, hepatomegaly, there will be a family history, jaundice, they can have history of high drops and intractable hiccups. Again, high ammonia can cause intractable hiccups. Now first line investigations, Dr. Ganesh gave you the mnemonic of the GALAC. Okay, so glucose, ammonia, lactate, electrolytes and ketones, and then your basic LFT, your RFT will give you the electrolytes, and specifically depending on the situation you will decide on CPK, LDH, cholesterol and triglycerides, and urine for ketones, and also look at the order, the reducing substances and the pH. Second line investigations we discussed would be your tandem mass spectrometry, then HPLC and the other investigations, which will also include neuroimaging. Other thing is, always send when you do a CSF for lactate, pyruvate, and you should always do sugar, okay, because you can find a low sugar in GLUT1 deficiency. Then subsequently you would do enzyme estimation and then mutation analysis depending on the situation. Now this again I don't need to mention again, he has very clearly mentioned it has to be a free flowing sample, should be sent immediately in ice pack, and it should be processed immediately, both for ammonia, lactate and pyruvate. Okay. Yeah. So now this is just to sum up. We already said if there are ketones positive in the urine, okay, with ammonia maybe not very high but high, it most likely MSUD. Of course, don't by heart these, you keep doing it, you would know, because we don't see that many metabolic disorders. I don't know whether it is just that we don't see or we are not able to diagnose. Okay, so acidosis with hyperammonemia, with lactate and a pancytopenia, we already said, they are commonly seen in organic acidureas. Okay. So again same all that we discussed, lactate, acidosis with ketones, maybe respiratory chain disorders, maybe a congenital lactic acidosis, and we know a huge hepatomegaly with hypoglycemia points towards GSD, and we discussed the points for galactosemia as well as for hereditary fructose intolerance. Okay. So we said ketonuria in the newborn, very very uncommon for a child to have, a newborn to have ketones. So if it is present, think of organic acidurias or maybe a mitochondriopathy. Now when you have hypoglycemia but no ketones, most likely it is a fatty acid oxide deficiency, or of course other thing is hyperinsulinism. We are not going to discuss those things in detail. And glutamine in plasma, which is a very sensitive marker of a UCD. Acute management, we just said correct the hypoglycemia, bring down the ammonia, control the seizures, and then other supportive management. Okay. And most of the time why do we give megavitamins? Because they all form a for all these enzymes there is some coenzyme which all need a vitamin. So that is why we generally give a megavitamin till we really know what is it that we are dealing with. So this is just a flow chart. So when you are thinking in terms of inborn disorders of metabolism, you do ammonia. Okay, if the ammonia is normal and there is no acidosis, then you think in terms of aminoacidopathies, galactosemia, and then peroxisomal disorders and non-ketotic hyperglycinemia. Now if the ammonia is high, now in newborns it is, we will consider even more than 100 is taken as hyperammonemia, but more than 200, then if there is acidosis, there is hypoglycemia and ketosis, you think in terms of organic acidemia. If the ammonia is high, you have done an ABG, there is no acidosis, there is no ketosis, it is urea cycle disorders. Now if there is a high anion gap with the hyperammonemia and no ketones, then it is maybe an acyl CoA multiple dehydrogenase deficiency or a fatty acid oxidation defect. Now if there is ketones with lactic acidosis, then you do the lactate pyruvate ratio. If the lactate pyruvate ratio is normal and there is hypoglycemia, most likely it is either a GSD or a defect in gluconeogenesis. If the glucose levels are normal, then it may be a pyruvate dehydrogenase deficiency. Now if the lactate pyruvate ratio is high, then you think in terms of pyruvate carboxylase deficiency or a respiratory chain defect. If you have ketones with lactic acidosis and skin manifestations, most likely it may be a multiple carboxylase deficiency, and if you have specific body odors, then you know that we are dealing with some specific amino acid defects like MSUD, PKU and all that. Okay. So, I mean it sounds very simple when you read it as a flow chart, but I know in practice it is not that easy. Thank you. So thank you for the patient hearing. So I think we will close today's discussion. Thank you.